it's like a 50-50 split, you know, so we try not to do, you know, lectures that were given in years past, and we try to keep it fresh, and that's why every 2 years there's a conference, so there's something new, but I think that we should, you know, certainly the new-timers should talk to the old-timers about therapeutic strategies. I think that, you know, someone came up to me and mentioned that, oh, I had no idea that acetazolamide came in immediate release. I thought it was only sustained release. Many times people come to conferences and they thought that potassium only came in a pill that was sustained release and didn't realize that it comes in a packet that you can drink, and that can be life-changing for different people. So to appreciate all the different therapies, we kind of haven't addressed too much of that this conference. There's a lot of subtleties about therapy that there's a lot of rich information to have there. Then a couple of people came up to me privately to ask questions, but I think the answers bear repeating to everyone, so I just wanted to take a couple of questions. First of all, Dr. Kennedy, are we recording your thing, or can we put it on the website? Is that a secret?
No, nothing's secret.
Okay. So,
put it on the site, yeah.
Thank you. Thank you very much. Okay. Then Noreen. Where's Noreen? Oh, okay. We got to get you a mic.
So the question that I asked, my name is Mary and I'm from Canada, and I've had periodic paralysis, hypo, for 11 years, just been diagnosed in the last 5 and had the same kind of misdiagnosis that it sounds like lots of you have had. And I have what I think is a great neurologist. I don't take any medication at all, and that's part of what I've been interested in hearing about here, just everyone's story of things they've taken. We've just chosen not to be on a medication to this point, so that's something I want to learn about. But the question I was asking is, what really defines an attack? Because I hear people saying they have 36-hour attacks, they have, you know, days, and I've always defined my attacks as the time that I'm in full paralysis. So for me, I have absolutely no warning. I am just instantly in full paralysis from the top of my head to the tip of my toes. The only thing I can do is blink my eyes. I'm able to communicate with my family through blinking and, you know, whether we need to go to the hospital or if I'm okay. And so I've always defined an attack as the minute I go into full paralysis until the time that I come out of it, which is anywhere from 2 to 6 hours. But following that, I've always then called it my recovery time, which does take about 36 hours, because then I'm sleeping, I have complete weakness, but I've never thought of that as an attack. So my question was, what does define an attack? And what sort of, and not that I want to be rated as a severe, but what does sort of constitute like high frequency, sort of a severe attack, is my question.
Great, so that's a good question. I'm going to call upon Dr. The two things are, one, does no therapy, is that, like, if you don't have that many attacks or you choose not to have any therapy at all, is that dangerous? Does that predispose you to more permanent muscle weakness or not? And then, you know, this concept of definition of an attack, I think that they've struggled with that in clinical trials. Maybe you could talk to that.
Okay. So, first of all, I think there is a role for lifestyle management, be that level of activity, diet, and things like that, and I would be a full advocate for that. So even though I spent a lot of time talking about these new drug approaches, I'm still a big proponent of lifestyle changes. I think that's the first approach towards this. With regards to severity and frequency, I'm still learning from you all. And you're right, there's an uncertainty in terms of when it exactly starts and when it ends. I've heard some patients say they know it's coming. They know it's coming with enough warning to be able to try and intervene, take some potassium supplement or something like that. Others, it comes very quickly. You know, the textbooks emphasize the brevity of these. I think the brevity part probably got there from the way medical care is delivered in the emergency room, and you're now strong enough to go home, which does not mean you're back to 100%. So I think it's probably underrepresented. I hear from many of you that it can take days to weeks before I'm back to 100%, so I think that's there. And the third point I would comment on, I think this is an open question that no one knows the full answer to, but as I was referring to, there's a very large family in the Netherlands, actually, that has the calcium channel R528H mutation. And many of the women do not have the transient episodes of weakness, and yet in their 40s and 50s begin to get the permanent muscle weakness. So that to me means there certainly can be a dissociation. You don't have to have the intermittent attacks in order to be at risk for the permanent weakness. What I don't know, and I don't think anybody knows, is are you putting yourself at risk or danger if you have uncontrolled or frequent or severe transient attacks? I don't think anybody knows the answer to that question yet. I certainly would like to.
Thank you so much. Then Monica was, where's Monica? So just to paraphrase one thing. You said that doctor gave you Norvax and Lodipine because it's a calcium channel. So if you could comment on that.
So this was an approach that several physicians reasonably tried when the genetics first came out in the mid-90s that hypokalemic periodic paralysis is caused by a calcium channel mutation. And it was a reasonable logical sequence because if the muscle is depolarized during an attack, that would mean something like calcium is coming in. So I've got a mutation in my calcium channel. Why don't I give a calcium channel blocker and try to help the situation? And it turned out that it didn't work, and now we know why. The mutant channels are leaky, but the leak is not through the normal conduction pathway, we call it, the normal channel that calcium goes through. It's in a different part of the molecule because of where the defect is in the mutation. So those drugs turned out not working. If the calcium channel problem had been abnormal, incorrect entry through the conventional pore, that might have worked, but it didn't.
Thank you. And then you had a special clinical situation that I just thought, maybe some other folks may have that or not, and just so you can chit-chat after that.
I suffer from hyperreflexes, and no one can tell me why, and I don't know if it's, when they gave me the calcium channel blocker, it actually gave me muscle spasms. And I didn't know if you were talking about excitability with someone that had the sodium and the calcium mutation. And I didn't know if the hyper reflexes was a symptom of that.
So, hyper reflexes, you mean when the physician uses the hammer that they're exaggerating. So, those are traditionally thought to be related to the way the nerves are controlling the muscle, not the muscle itself. So you don't get hyperreflexia from a muscle situation. For the conventional channels that are affected in hypo or hyperkalemic periodic paralysis, those channels are overwhelmingly, predominantly in skeletal muscle. Chris Lawson has found there in some other tissues at lower extents that might be responsible for some of this. But I would not expect that to be an end result of having hypo-PP or hyper-PP in what's in the muscle. Now, as we've heard, and Dr. Siegel asked a question about, now that we're beginning to think about all these shifts in the concentrations of ions, well, every electrical tissue can be affected. So patients with hypo-BP know when your potassium gets too low, your heart's not real happy, right? You begin to get arrhythmias. Well, it's conceivable that some of the other ion shifts associated with this could secondarily affect other tissues like nerve and things like that. So that's the only way I could try to connect the dots. But otherwise, I can't tie it because the relevant channels are not in the nerve, and that's definitely a nerve issue with the increased reflexes.
Thank you. And I'm sorry, just one last thing. So you were saying you have low potassium, low sodium, high?
When I have an episode, I found that my threshold is anything that drops below 3.8, then I get paralysis, or I get spasticity, I get all kinds. It's like rolling the dice. but I also will suffer from low magnesium, and I can also suffer from low sodium. So my doctor recommended me having sodium. Well, today I had salt in my eggs, and I can feel it already starting to affect me, and I don't know if that's what it is or not, and so now I'm starting to question, even though I suffer from low sodium, should I still be taking in salt?
I had a question with regards to that. Are these levels low even, are these levels low just during episodes, or are these levels low even in between episodes?
Well, when my doctor was having me go in once a month to be tested, and I was not within an episode.
Not with symptoms.
With no symptoms. Well, I mean, I have symptoms every day. I have spasticity. I have like some
Right.
symptom of it, but not an episode. As long as I'm above 3.8, I'm fine. But if when I go to the hospital, it's to the point now where I can tell by my symptoms what my blood's going to be. It's to that point. But I'm finding also that my threshold seems to be raising up. Like the amount of potassium I have to take every day keeps going up.
So what are the secondary causes?
So, as Dr. Trivedi was just mentioning to me, there can be secondary causes of malfunction of muscle, nerve, and heart if the electrolytes in the body are out of whack. Normally, the body does a pretty good job of maintaining those, so unless someone has kidney disease or is using diuretics in an ill-advised way, or has a lot of vomiting or diarrhea or something like that that would set it off, your body does a pretty good job. But I'm glad you raised these points, because I want to emphasize that while high concentrations of salt, the dehydration state, high salt diet could be a problem, you never want to have too low a sodium level either. So that's very bad for all the excitable tissues. So you need to, maintain a bit of modicum and normalcy in all of these things. So you wouldn't want to completely cut it out, but just wanted to make people aware that excessive salt intake could be a problem in that regard. I think we should move forward so that we can try to stay on schedule. And Jake Levitt kindly allow me to introduce Dr. Jaya Trivedi, whom I'm very pleased to do so, because when I went to Texas in 2002, Dr. Trivedi was a young neuromuscular specialist in our department, and she was very curious in learning about myotonia and periodic paralysis, and we worked together for a while and connected her with vertebrates, and she really took off and has done some seminal work in use of medications for non-dystrophic myotonia and the natural history of myotonia. And I'm really proud to have worked with her and seen her development in her career. She's now a professor of neurology at UT Southwestern.
Thank you. Thank you very much, Steve. Thank you for the kind introduction. And I want to thank Dr. Levitt and the organizers of PPA asking me to come here to give a talk. And I appreciate everybody's presence here and all the questions. And I have a habit of moving around, but I have to stay stuck behind the podium because there's audience out there. And I have allergies, I have coughs, I have my water here, so please bear with me. And Dr. Cannon has very appropriately said, all of us physicians feel that we learn a lot from our patients. I really never thought of myself as a periodic paralysis expert, and I don't think of myself as one even today. I think I just get to see a lot of patients with periodic paralysis, and that's helped me learn a little bit more of periodic paralysis. So like everybody says, the education has come a lot from patients. And I was fortunate to work with Dr. Cannon. He's been one of my big mentors, and Dr. Briggs in helping me work towards clinical research studies in channelopathies. So Dr. Levitt wanted me to talk a little bit about myotonia too, and we have Dr. Christoph Lawson, who's done a lot of work, and he'll discuss furthermore. The emphasis in my talk is going to be about clinical manifestations of periodic paralysis and a little bit about on myotonia. So this is a huge spectrum, as you can see out here, and these are diseases of the muscle ion channels, which Dr. Cannon has talked about. To the very left end is the spectrum of myotonic disorders. To the very right end out here is a spectrum of periodic paralysis or acute attacks of weakness. And as you can see in myotonia out here, we have different forms of myotonic disorders. Some of these are called myotonia congenita, the autosomal dominant or the autosomal recessive forms. And what you heard about in the previous talk was paramyotonia congenita, which is related to sodium channel defect. To the very right, this audience is very savvy, as he said, and you guys know hypokalemic periodic paralysis linked to two mutations, sodium channel and calcium more common than sodium. Hyperkalemic periodic paralysis, and we'll talk briefly about Anderson-Tawil syndrome, a third type of periodic paralysis. So while patients have hypokalemic and hyperkalemic periodic paralysis, they have distinct differences between the two. But there are some common themes out here that all patients with periodic paralysis share, whether it is hypo or whether it is hyper. These symptoms of attacks or weakness, and we'll talk a little bit more about what is an attack, starts in the first decade or the second decade usually. It's usually uncommon, unlikely for the start of much later years. It is autosomal dominant, meaning that if somebody has periodic paralysis, either hypo or hyper, there's a 50% chance of passing it on to the next generation. Typically, as many of you have identified, patients can report triggers. They will know that, okay, this is what triggers my episode, whether it's hypo or hyper. It's a very rare patient who will come to my clinic and will not recognize or will not know of what triggers bring on the attacks. And it's very important for us physicians then to advise them to keep a diary of their attacks and then go back to what had happened 24 hours or 36 hours before. Was it exercise or was it a certain diet? These attacks are associated with a low potassium or high potassium. The dilemma is with a high potassium, it's very hard to capture high potassium with a blood test. A low potassium is more easy to capture. Usually patients will have in-between attacks normal strength. But as mentioned earlier, with recurrent episodes of weakness over years, patients will eventually develop weakness in arms and legs, where they have difficulty lifting their arms above their head, without difficulty getting off the car, getting out of the car, getting off a low seat. Those are problems that patients start developing in the later years, 30s, 40s, and later. And there is evidence now that certain medications, such as the carbonic anhydrase inhibitors, can reduce the frequency or the severity of these attacks. And a very important question comes up that has not been fully answered, that taking these medicines do prevent long lifetime weakness, permanent weakness. Moving on, more focused, hyperkalemic periodic paralysis. And again, this is a very basic description, and many of you are aware of these symptoms. The weakness attacks, people can have, and this is what I learned from Dr. Griggs, always ask patients, they think about talking about major attacks when they're completely paralyzed, when they cannot move. But when we started doing clinical trials about 8 to 9 years ago, we learned that it's important, or I learned rather, it's important to ask about minor episodes. Like, patients not always think about the major episodes, but are you having times when there's some difficulty doing things which you used to do and that day you cannot do? It's not a full attack, but it's what we call a minor episode. So it's important to track minor episodes as well as major episodes. In hyper-PP, the duration can be shorter compared to hypokalemic periodic paralysis, lasting a few hours. Infrequent, it can last up to few days, and triggers are many. This is just a brief list out here. Starvation is also an important trigger for hyperkalemic periodic paralysis. And like I said earlier, potassium levels are usually very hard. Elevated potassium levels are very hard to identify during an attack for these patients. Very rarely they can have difficulty with speech, swallowing, or even breathing muscles. And as we talked about, recurrent episodes over years will lead to fixed weakness, which affects morbidity. So this was a paper published, actually Dr. Levitt, you were the senior author on this paper, I found it. And this was a paper taken out of surveys, about I think 135 or 137 people who responded to surveys. And there were lots of questions asked. I just put this up here because I've seen so many patients now asking me, this is my trigger, you think this is a trigger, and it's very hard to tell. And I think this slide out here just gives an example as to how different kinds of patients can perceive different triggers. There are some triggers that are common to everybody, rest after exercise, starvation, and hyper-BP. But this is from the survey, and you can see cold, rest after exercise. Now we have a very good explanation from Dr. Cannon's experiments. Stress, fatigue, alcohol, hunger, changes in activity level, as understood, potassium-containing foods, humidity, pregnancy and menstruation. In fact, people have talked about estrogen effects in myotonia. There must be some correlation that estrogen affects these patients. And illness of any type. Frankly speaking, most neurological disorders, be it periodic paralysis or multiple sclerosis or myasthenia gravis, other things, infections, illnesses can make symptoms worse. In hypo-PP, typical features again, minor episodes, major episodes. Duration can go up to days. Like the lady from Canada said, her episodes The max weakness lasts for a few hours, but you feel weak for up to 36 hours, and that's not uncommon with hypo-BP. Triggers, carbohydrate meals, stress, alcohol, rest after exercise. It's really gratifying, Steve, to hear your experiments, how it showed that rest after exercise brings on attacks. In these patients, if they have a long enough attack and if they're in a medical facility, it's more easy to pick up a low potassium as compared to patients with a hyper-PP form, so it's hard to pick up the high potassium. And these potassium ranges can be 1.4 to something, up to 3 also. And these patients can sometimes, when they are very severely affected, it can affect the breathing muscles, they can't talk very well. And again, over years, they can develop fixed weakness which affects morbidity and lifestyle. Anderson-Tewel syndrome. So this is more rare than hypo or hyper-PP. About 1 in a million people can have Anderson-Tewel syndrome. I think in my clinic, I'm actively following perhaps just 3 patients with Anderson-Tewel syndrome. It's a very rare condition. So besides having periodic paralysis, they can have 2 other features. One is that affects the heart, causing cardiac arrhythmias, or something causing prolonged QT interval. I have an example, I'll show you in the next couple of slides. Dysmorphic features, meaning physical abnormalities. Certain physical abnormalities. So if somebody comes to our clinic with periodic paralysis, and a history of some cardiac abnormality, or if on the physical appearance we can pick up some abnormalities, then we start thinking, could this be Anderson-Tewel syndrome? And some of these patients have a mutation related to the potassium channel gene, which is not the sodium, not the calcium, that is seen in hyper or hypo-PP. This is just taken from a book, a paper about the physical abnormalities, some of them that you can see in patients with Anderson-Tewel syndrome. Let me find my mouse to demonstrate the findings. So this on the side profile out here, the jaw is small, what is called micrognathism. The ears are described as low-set ears. If you take a line from this outer angle of the eye and draw it, the ear starts below that. That's a low-set ear. If you look at the front picture out here, the forehead is broad, the eyes are wide apart, and the base of the nose out here is wide and flat. Now, it's not uncommon for people to have broad foreheads and things like that, but in the right context of periodic paralysis, if you see these features, that prompts you towards Anderson-Tewel syndrome. In this hand out here, the pinky out here is slightly curved, and that's called clinodactyly. Sometimes, not seen very well in this picture, you can see webbing, where if the patient spreads the fingers, you can see a little bit of webbing in the fingers or the toes, and that's called syndactyly. This is just a very small EKG strip. The heart rhythm is just off out here, and that's a ventricular arrhythmia. This is a black and white picture, better pictures later, of a muscle biopsy. What you're seeing out here is, this is one muscle fiber, muscle fiber, muscle fiber, muscle fiber. These all look fine, but in this muscle fiber, there is something, an aggregate in the center, and that's called a tubular aggregate. And I want to emphasize that a muscle biopsy is not something that helps make a diagnosis of Anderson-Tewel syndrome. It's just that in some patients, you can see these biopsy abnormalities. Now, does this make the final diagnosis? No, because tubular aggregates can be seen in other neuromuscular conditions, not necessarily Anderson-Tewel syndrome or periodic paralysis only. And that is why we clinicians don't think this is very useful in making a diagnosis of periodic paralysis or Anderson-Tewel syndrome. This is taken from one of Dr. Levitt's slides from a previous presentation. What you see on the top panel here is a normal EKG. So when our hearts beat, for each beat, there is this complex. It's called the PQRST. That's one beat, and this is second beat, and that's where you measure heart rate. But each beat has these different complexes. The Q starts here, the QT interval. This is your QT interval. And what you see in Anderson-Tewel is, and that's where I defer to our cardiology colleagues to look at Holter tests and EKG tests to see if the QT interval is prolonged, as seen in this example out here. So prolonged QT interval with episodes of periodic paralysis make you think about Anderson-Tewel syndrome, and genetic testing will be pursued accordingly. Now, I thought I'd change the slide a little bit. Again, this is one of Dr. Levitt's borrowed slides, and this brings up the same point that Dr. Cannon was talking to. Is it Maureen? Monica, sorry. So there are patients now, and if my potassium goes low today, if I have diarrhea for 5 days, and my potassium goes low to 2, I will have an attack of paralysis. That does not mean that I have primary periodic paralysis. That is what we call a secondary periodic paralysis. So that's a very simple example I gave you. In hyperkalemic or hypokalemic periodic paralysis, the potassium changes occur during an attack. In between attacks, the potassium is normal. But if I have diarrhea, like I said, my potassium drops, I go into the ER, I can't move. Right? But if somebody has low potassium, even in between episodes, that or high potassium in between episodes, then they can certainly develop attacks of weakness. But then it is a secondary case of periodic paralysis, not a primary case of periodic paralysis. How often do we see this? I do see it a few times. I had a young man who came from Oklahoma to see me many years ago, and it's just that I'd read a paper on something called the Gittleman syndrome or Gittleman syndrome, and so I knew he was diagnosed with Gittleman syndrome by his kidney specialist. And that's a syndrome that causes potassium wasting. So if his potassium stays low all the time, I mean it goes much lower, then he has attacks of paralysis. So he has what we call a secondary form of periodic paralysis, not the primary form of periodic paralysis. And that's important to distinguish because you can direct the patient and the management appropriately there. And so this is just a list of kidney causes, certain medications, certain endocrine causes, adrenal gland problems, kidney problems can affect your potassium. Of hyperkalemic periodic paralysis, again, one of the kidney conditions called renal tubular acidosis type 4. Type 1 and type 2 drop your potassium. Type 4 increase your potassium level. So there's some of the conditions that can cause hyperkalemia, and so those are secondary causes of periodic paralysis. So diagnostically, if somebody has a classic presentation of early onset attacks of weakness, family history, and other supportive data, you don't have to do a huge exhaustive testing. But that's a very small number of patients. Many patients have atypical, we can't identify the low potassium or high potassium during a spell. There are various other reasons why we can't really make a diagnosis, and that's why we still search furthermore. We do electrophysiologic testing called prolonged exercise test. We check their thyroid function. We check the EKG. We do testing for the adrenal glands, for the kidneys. Sometimes I refer them to kidney specialists, the nephrologist, to make sure there's no other kidney problem causing alterations of sodium and potassium. So these are various tests that can be performed in these patients, in our patients with suspected periodic paralysis. What I wanted to touch base about, because this is a question I get posed quite a bit in my clinic when I have patients come in for possible periodic paralysis. This is a test called the prolonged exercise test. Am I okay with time? So prolonged exercise test was first identified as a useful test by Dr. McManus, published about 20 years ago. And then Dr. Fournier and colleagues from France, who also do a lot of work in periodic paralysis and channelopathy, they modified the protocol, and we've used the modified protocol in our clinical trials. So what we do is, this is really not a patient going through a prolonged exercise test. This is a different patient, and I'll tell you what is the difference. But what I wanted to demonstrate out here is that this is what we do. We stimulate the nerve at the wrist, and we record the response in the inner part of the hand, or the pinky finger, and the muscle that controls the pinky finger is right here. So if you spread your pinky finger, it's this muscle that helps you spread it. And that's where we record the response from. Why this is not one of my patients with periodic paralysis is because in periodic paralysis, in prolonged exercise test, we get baseline response as to what the nerve response should look like, and this is what it looks like. This is called the CMAP, or the amplitude response, and this is what we are measuring when we stimulate the nerve. But what I do in prolonged exercise test is we strap the hand and strap the wrist. Because I'm going to have the patient exercise, and I'll tell you how. And I do not want any inadvertent movements from discomfort affecting the patient's hand mobility. So you have to make sure that you strap the hand, split the hand, with the fingers and the wrist stay immobile. Because this test can take up to an hour. So what I do is first get baseline estimates. Then we have the patient exercise that pinky finger, that muscle there that is being recorded. And how do we do that? You exercise the muscle for 5 minutes. It's hard to keep the finger like that for 5 minutes, pushing against a splint. So exercise 15 seconds, take a break. Exercise 15 seconds, take a break. At 1 minute, you get shocked, measuring a response during exercise. So you do this exercise, stop, take a break, exercise for up to 5 minutes. And once the exercise is complete, the splint is kept in place. We don't remove the electrodes, we don't move the stimulation. And the patient is just resting, not moving the muscle, and we keep stimulating at the wrist every 1 or every 2 minutes, up to 30 minutes or up to 15 minutes. And what are we looking for? We're looking for this. So there are 4 examples out here. This is a controlled patient, meaning somebody who does not have a neuromuscular disorder. This is somebody with hyperkalemic periodic paralysis, hypo-PP, and Anderson-Tawil syndrome. These are not all the tracings. We collect about 50 or 60 tracings. This is just a few of them, demonstrating in a healthy person without the disease. This is your baseline before exercise. Look at the size of the response. After exercise, the response is still there. And after exercise is done, you keep stimulating up to 40 minutes, and look, the size of response stays about the same. No major difference. But in patients with hyper-PP, some of them, not all of them, the baseline response is small. You exercise, it goes up a little bit. But after the exercise is done, you're just stimulating, and look what's happening. The response is getting smaller. And this is called the Cmax decrement, and becomes, and sometimes, so small that it's barely readable. The same thing in hypo-PP, your baseline response, exercise the muscle, and post-exercise, look what's happening. So after exercise, the response keeps dropping. In Anderson-Tawil syndrome, the same thing happens. So if I could make an important point out here to the audience, prolonged exercise test is technically very difficult to do. It should be done in the right hands. People who know that splinting, immobility is very important, because any movement can affect the reading, and it might be a false positive or a false negative test. The second important thing is, this exercise test can be normal in about a third of the patients with true periodic paralysis. So somebody with periodic paralysis may have a normal test. Or, secondary cause of periodic paralysis, even in those patients, this test could be abnormal. So while this test is helpful in getting more objective evidence, we have to remember there are caveats. It's not 100% foolproof. Muscle biopsy, I just bring this up because I have patients who ask me questions about the muscle biopsy. Now again, I'm repeating, a muscle biopsy is not useful in making a diagnosis, but this is what a normal muscle biopsy looks like. One fiber, next fiber, all these fibers compacted closely together, look nice and normal. Some patients, not all, a few patients with hypo-PP or Anderson-Tawil syndrome can develop these features called tubular aggregates or vacuoles. It's the same muscle biopsy, stained differently. This stain picks up these structures in a muscle fiber. If you remember, there should be nothing in the middle of the muscle fiber. But here, these structures are called aggregates. And here, these holes on this stain are called the vacuoles. If I could repeat a third time, aggregates and vacuoles do not make a diagnosis, because aggregates and vacuoles can be seen in other kinds of neurological problems, certain kinds of muscular dystrophies, certain kind of hyperexcitability syndromes. So this is really not the way to make a diagnosis of periodic paralysis. So diagnosis of periodic paralysis, how do we make a decision diagnosis? Classic attacks of periodic paralysis, low or high potassium during an attack, with normal potassium in between attacks. Do the prolonged exercise test, you find the decrement. Make sure there's not a secondary cause, the adrenal gland, the thyroid gland, the kidney function, all those things are not causing the periodic paralysis. But there's a classic family history. This is a perfect setup. So if somebody asked, how do we determine in clinical trials, and that's where the dilemma comes up. In the big international study that was completed in periodic paralysis, which led to the approval of dichlorphenamide, that was the biggest challenge, finding patients who fulfill what we call the criteria. And it's very hard to find these criteria fulfilled in every patient. And many of you know what I'm talking about. Genetic testing, of course, confirms the diagnosis as a gold standard, but this is where the big challenge comes for, not only for patients, but for physicians. But I think it's the patients at the receiving end who search for a diagnosis when we can't find these abnormalities. Principles of management of periodic paralysis, basic tenets of treating periodic paralysis. And this is where we talk to patients, and most patients are so savvy. They know their triggers, they have their diaries. But there are some patients who don't know their new diagnoses, they don't know, and you have to advise them to make diaries of identifying triggers. Identify the triggers, lifestyle adaptations, can't repeat that enough. Abortive therapy, meaning during an attack, acute therapy, what can be done to reduce the attack or get rid of the attack. Prophylactic therapy, meaning what can be given to prevent attacks, and genetic counseling. These are genetic disorders. There's a big chance of passing it on to the next generation. And so once you make a diagnosis, it's important for patients, especially the childbearing patients, to see genetic counselors. The basic things of hypo-PP and hyper-PP. In hypo-PP, frequent small meals, low salt, low carbohydrate, avoidance of alcohol. Hyper-PP, avoid potassium-rich foods. I used to always think of bananas as rich in potassium, but bananas have a lot of carbohydrates, so be careful there. The amount of potassium is not enough to overcome the effects of carbohydrates. But typically, higher potassium-containing foods are spinach, squash, potatoes, but it has to be one whole cup. That will give you about 15 to 20 millimoles of potassium. And oral carbohydrate snacking during an attack of hyper-PP is usually useful. So this is a busy slide. I don't mean to read everything from the slides, but this would be on the website, I take it, so people can look at it later. But during an acute attack, abortive treatment, potassium can be given orally or intravenously depending on how severe the attack is. Oral potassium, everybody requires different. For the first time, first patient, first dose, you start off low because you don't know what each patient will respond to. You don't exceed 200 millicoulombs a day. You can go from 0.5 to 1 millicoulombs per day. If it's in the intravenous form, there's certain dosage, certain recommendation not to exceed so much potassium in 1 hour. There's certain recommendations for that. More importantly, it's important for physicians to be aware that when giving intravenous potassium, use it in a mannitol solution and not glucose or saline, because that's going to make the attack worse. There are certain times when you cannot use intravenous potassium or oral potassium. There are certain side effects. For people who take the oral potassium, it causes gastric irritation. It can cause some diarrhea too. So if you take a lot at the very beginning, people may not think that this is useless. This is terrible. It hurts my stomach. I get diarrhea. To start off low, you have to define the fine line for each individual. And that is the individual who finds that as to how much is enough and how much is too much. And there are special points I would just like to make. For every 20 milliequivalents of potassium taken, the change in the blood is about 0.5. And avoid potassium, like I said, in saline or glucose infusions. And if somebody is having a severe attack requiring a lot of potassium, it's advisable to monitor the heart rhythm on something that we call telemetry, because it can affect the heart rhythm, potassium supplementation. Hyper-PP, oral carbohydrate snacks during the acute attack. There's some category of medications called beta agonists, very popular in treating asthma patients, called salbutamol or albuterol. It drives the sodium-potassium balance, and it might help in hyperkalemic periodic paralysis during an acute attack. But these inhalers sometimes cause palpitations, a sense of jitteriness, tremor, nausea. So you have to be careful. You don't want to give it to pregnant women with high blood pressure. So there are certain indications you have to be careful where you don't use this too much. And calcium can be used intravenously too. Prophylactic treatment. Now the next two slides are talking about prophylactic treatment, and this one applies to both hypo and hyper-PP patients. So acetazolamide, one of the oldest tried drugs in preventing the attacks of periodic paralysis, works well. But in a nice paper published by Dr. Hanna, who's a very, he's done a lot of work in channelopathies in UK, he has reported that about 50% patients will respond and 50% may not. And calcium channel patients are more likely to respond better compared to sodium channel mutation patients. The key point is that there are some patients with sodium channel mutations who might notice worsening with acetazolamide, so be careful. Do we know up front with our genetic testing which patient will or which will not? No, we can't tell that. The standard dosage is as you see out here, and like he said, there's immediate release and extended release, both formulations are available. Certain conditions we should avoid it, kidney disease, liver disease, those kinds of conditions should avoid this drug. Side effects, I tell patients initially they can have some metallic taste in the mouth, or some numbness or tingling, rarely some confusion. Electrolytes and blood counts could be monitored initially more frequently, but after somebody's been taking for a long time, maybe once in 6 months or a year. Excuse me. Sorry, that was very loud. Okay. I thought it was your job to cut it down. You don't know what I'm going to be calling. Okay, for periodic paralysis, the second most interesting drug everybody's been talking about is a didropamide, or Kivase. And just got approved a few weeks ago, perhaps August, September, I'm blanking out when. And this is really not a 9-week trial, but there was a big research study done internationally. UK, Canada, France, Italy, and many centers in the US were involved. And we were involved in UT Southwestern too, and Dr. Griggs was a leader behind this. And looking at patients with hypokalemic periodic paralysis and hyperkalemic periodic paralysis. And one of my research participants is here in the audience. And without patients like you, Selena, there would not be a study like this. So this was to look at dichlorphenamide compared to placebo or a sugar pill to prove if dichlorphenamide works or not. It was a 9-week period where half the patients or some patients got the sugar pill and some got the real pill. And then for many months when that was done, there was a 35-week or a 32-week study where everybody got the drug. And the purpose was to see if dichlorphenamide reduces the attack frequency, and it did. It worked in hypokalemic, though more than the hyperkalemic periodic paralysis. It's 5 times more potent, as Dr. Cannon said, than Diamox. So starting dose is lower compared to Diamox. And similar side effects, similar precautions, perhaps a little bit more confusion with this drug, confusion of side effect with this drug as compared to Diamox. In hypokalemic periodic paralysis, for those patients who have inadequate or no response or worsening with acetazolamide or dichlorphenamide, the other options include 2 categories of drugs. This is one category of 3 drugs, triamterene, spironolactone, amiloride, called potassium-sparing diuretics. So these are water pills which preserve potassium. And the first one is called eplerenone or Ispra, which works differently. Spironolactone is a pretty popular drug, used quite a bit. The downside is it can cause breast enlargement and tenderness, which is called gynecomastia. Using eplerenone, you can avoid that. So sometimes patients are taking both Diamox plus the eplerenone. It's okay to use combination if needed. However, one must remember that you must use medications at different mechanism of action rather than just duplicating the same medication in different form. For hyperkalemic periodic paralysis, besides Diamox and dichlorphenamide, you can use a water pill called hydrochlorothiazide, which basically is a potassium-based thing. You pee and you pee the potassium out. So that's a medicine used for high blood pressure. Thyrotoxic periodic paralysis is a condition where it is more common in Asians, but it's in other ethnic populations too. You have hyperthyroidism, so the thyroid gland is hyper-functioning in these patients. And some of these patients have a defect in the potassium channel, just like the patients with the Anderson-Tawil syndrome. The triggers are similar to the triggers with hypo-PP, and duration of these attacks can last for hours to days. And because they have a hyper-functioning thyroid gland, they'll have symptoms from that, which is nausea, vomiting, diarrhea, weight loss, palpitations, sweating, things like that. And their potassium levels during an episode are very low. And so we always check thyroid functions for anybody who comes in with possible periodic paralysis. We treat the thyroid condition, they should get better. You also prescribe medicines like propranolol or potassium, but you do not use acetazolamide in these patients. Jake, how are we doing at time?
We have
10 minutes. So my emphasis was on periodic paralysis, but I believe there are some patients with myotonic disorders. We actually call it non-dystrophic myotonia. We were talking of myotonia congenita or paramyotonia congenita. I just changed my title to myotonic disorders 2 days ago because I said if I put non-dystrophic myotonia, it might confuse people. But there are many kinds of myotonic conditions, including myotonic muscular dystrophy. I'm going to focus on myotonia congenita and paramyotonia congenita because these are also ion channelopathies of skeletal muscle. So what we say about myotonia, and I actually had 2 or 3 slides out here, but I took them off because I had patient pictures in that. And I don't know if this goes somewhere else, and I didn't want my patient pictures to be put out in public there without their permission. But I had very good examples, and if I could show with my hand, what happens to these patients with myotonia is they squeeze their hand, and as they get...
Bring your hand to the camera.
Oh, sorry. But they can't see there.
Well, they can see up there, so I think it should work.
Where is my face? Okay. So patients make a fist, and when they relax, it's a very slow relaxation. I'm faking it. I could tell I would fail the myotonia test. But if I do the second time, and third time, and fourth time, my opening of my hand improves, becomes faster. So the initial delay of relaxation is the myotonia. But doing it again and again and again, it gets better and faster. That's the warm-up phenomenon. What is paramyotonia is the opposite. I squeeze first time, relax, it opens easily. Second time, a little bit difficult. As I do it third time, fourth time, fifth time, it gets harder and harder. So exercise or cold makes it worse. On Friday, I saw a family, 2 sisters. One of them was my research patient, and the other was her cousin, who came with her. And my medical students were with me and they loved seeing this. The patient opened their eyes, no problem. Second time opened their eyes, they could not open their eyes. Third time, it was much, much more difficult. That's eyelid paramyotonia or paradoxical myotonia. So this is just a video clip, not of a patient, but demonstrating when we stick needles in these muscles, you can hear the myotonia. And some of the hyperkalemic periodic paralysis who have paramyotonia, if you stick needles in the muscles, you hear the sound. If I move a needle in the muscle, I just hear trip, pause, Listen to the sound, it's a myotonia. People call it a dive bomber sound. To me, it sounds like a motorcycle revving up. The speaker turn on? That's myotonia. So I just want to tell you, these non-dystrophic myotonic syndromes are related to chloride channel mutations or sodium channel mutations. Myotonia congenita is chloride channel, and the paramyotonia and the hyper-PP paramyotonia is sodium channel mutations. Myotonia congenita, two forms, the dominant, where there's a 50-50 chance of passing it on to the child. The recessive form called Becker, where if both parents carry the gene, there's a 25% chance of passing it on the child. These patients will have myotonia. This is one of my patients with myotonia congenita. They develop a muscular physique. People think they've been working out the gym, but they don't work out the gym. It's years and years of continuous contraction muscle that causes this state. And somebody says like cantaloupes, and I think that's true. And about 100 mutations have been identified in the chloride channel for this condition. Very briefly, the differences between the Thompson's disease and the Becker's disease. In Becker's, they get these episodes of temporary weakness. And a young man, 16-year-old, who plays baseball, an initial run, he's weak, but he keeps running, he gets stronger. Sodium channel mutations, paramyotonia congenita, it's the opposite. It gets worse with exercise, gets worse with cold, but these patients have normal strength. There's a different kind of myotonia called potassium-aggravated myotonia, but potassium brings it on, but they do not get weak. So treatment options in non-dystrophic myotonia, unfortunately there is no FDA-approved medication for this. Various medicines have been tried to treat the symptom of myotonia, which is the stiffness. When there's myotonia, people have stiffness and pain and weakness. And various medications listed out here can be used. There was a big study we did as a big group, Dr. Briggs again as a lead, where we looked at mexilitine in treating myotonia, the symptom. And what we found was that the mexilitine medication at a dose of 200 milligrams 3 times a day reduced the stiffness, weakness, pain, improved quality of life, and reduced the myotonia that was seen on EMG and on physical exam. The side effects is pretty well tolerated, but about 15% patients in the study developed diarrhea. So that's something that patients might complain about, stomach upset and diarrhea from taking mexilitine. To conclude, periodic paralysis and myotonic disorders, specifically myotonia congenita and paramyotonia congenita, are rare diseases. To repeat, a normal prolonged exercise test does not exclude the diagnosis. A prolonged exercise test may be abnormal in secondary forms of periodic paralysis too. Genetic testing is the gold standard, but could be normal in patients with periodic paralysis and myotonic disorders. Treatment options are available, but like somebody said earlier, they're not a cure. And most important, lifestyle. Lifestyle changes, dietary changes are critical in treating patients long term. Thank you. With this, I end my discussion, and I'm open for questions now.
Oh, it's in the audience. Okay, oh, I'm sorry. It works out that the Rosen wants to have us out of the room now so they can prepare for lunch. And we have to come back in an hour. So please write your questions down, and we will pick up the questions after. My apologies, we kind of ran over a little bit. But Jaya,
Did I talk too much?
Awesome.
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 Talk too much?